It's an absolute privilege for me to introduce this session with the presentation focusing on consumer engagement as part of MASCC's strategic vision. And it's an extra delight to do it from my newly appointed position as Head of National Cancer Control at Cancer Australia, being known for its seminal framework for consumer involvement in cancer control, released in 2010. This, of course, is to precede our three wonderful speakers who are pioneers in their own right in empowering people affected by cancer through various means of support, leadership, advocacy, care provision, and meeting the person where they are. Anne McKenzie, Joanne Britto, Ian Olver. This is a global audience. In our own parts of the world, we use terms that aim for inclusivity for people that I like to refer to as experts through experience, but can sometimes slip into terms of convenience or labels that end up losing purpose of meaning. So I want us to really think about that today. When we talk about involving people affected by cancer for the betterment of service design and delivery of better patient experience, we use terms that include public and patient involvement, patient advocate, consumer, people affected by cancer. The snip of the article you see there puts forward different models of what the author terms medical consumerism, to refer to a history of the purchaser or receiver of health services having increasing choice over the services they receive and the extent to which they can influence how these are designed. The paper starts off with a quote: "Doctors as a whole do not like medical consumerism, and most academics are sceptical about it." Now, this has partly stemmed from what has been perceived as consumer challenges to professional authority, but it's evolved much more productively into a dynamic that strives to base itself on positive relationships between patients and professionals, including where patients' views and experiences are actively sought out to support system improvements. The article puts forward several views and what is meant by medical consumerism, and suggests that the term consumer has limited value in the aspect of understanding health services and how they've evolved, because the term is said to conceal as much as it illuminates. The paper goes on to say that the term can generate anxiety in a patient rather than reduce it. And it ultimately frames the consumer much more positively as communicator, explorer, and identity maker. So there is always a meaning behind a term, but it's important to get alignment on what that meaning is. In saying that, I will use the word consumer when referring to people affected by cancer from here on in, and in doing so, I acknowledge that this is not a universally favoured term. The National Framework for Consumer Involvement in Cancer Control is a well-researched framework that has been designed to facilitate consistent approaches to consumer engagement and to develop lasting partnerships with consumers. The figure depicts the four elements that have been identified as being essential for effective consumer involvement in cancer control: committed organisations, capable consumers, inclusive groups, and a shared focus. Together, these four elements describe the responsibility and the accountability of organisations and of consumers and groups more generally. Each element of this framework comprises criteria that will support effective consumer engagement. The elements are interdependent and all are necessary for quality improvement and sustainable consumer engagement. This figure sets out the different levels of consumer involvement opportunities. It recognises that the majority of consumers will be receivers of information, and that's shown as most at the bottom of the pyramid. Through asking questions, seeking information, and receiving key messages from organisations, consumers are able to build upon their own awareness and their literacy in engaging with the health system and understanding and managing their own cancer care and control. Some consumers may be working in partnership with professionals or organisations for mutually agreed outcomes, while a smaller number of consumers may lead cancer control activities. And we see that in the consumer-led component at the top of the pyramid. Happily, I can say that since this framework was first released, that this component of consumer leadership has really developed, and we're seeing more and more of that. The figure also describes the different skill set or capabilities that consumers need at each level of participation, as well as the necessary supports ideally provided by organisations to sustain this effective consumer engagement. So these frameworks serve a theoretical basis for many practical tools that are used to facilitate the greatest contribution within organisations or healthcare settings of consumer input. These frameworks remind us of the benefit and nature of effective consumer engagement. Looking to other cancer agencies and professional societies now, ASCO has the Conquer Cancer Research Advocacy Network training program for consumer grant reviewers. And this is an annual intake that supports consumers in skills to review grants successfully. Eligibility is a person living with cancer or a family member or their caregiver, and a high school level education. So no higher education is required. The Union for International Cancer Control delivered a master course to 93 participants in 2020 on multi-sectoral approaches for patient engagement for better cancer control. And the UICC aims to work with patient organisations to acquire the necessary knowledge and networking opportunities to voice their perspectives and feel empowered to have a say in research, care and support and survivorship programs, and can be considered as a driver for change in all health systems. Finally, the UICC also have a global patient group mentoring program aimed at building capacity of representative cohorts of patient groups and creating connections and global networks. I'm excited to report that MASCC now has a consumer engagement committee reporting to the board to drive effective mechanisms of consumer engagement within MASCC. This is a group of clinician, researcher, policy, program, consumer activists from around the globe who have a shared passion for putting people affected by cancer at the centre of all our cancer control efforts, and who can think strategically and practically about establishing routes within MASCC to enable this. Hannah Wardle leads research in South Australia on cancer treatment toxicities. Joanne Britto is a consumer engagement manager in Australia, focusing specifically on cancer. Andreas Charalambous has a focus on applied oncology nursing research in Cyprus, and Yin Ting is in the School of Pharmacy at the Chinese University of Hong Kong and focuses on cancer survivorship research, specifically in young people. Both Bogda and Mariam are medical oncologists, one in Australia and one in the US, with a special focus on survivorship research. Elaine Tomlins is a nurse specialist at the Royal Marsden Hospital in London. This is our first task, but we need to partner with consumers to get it right. Joanne, in her presentation, will walk us through how a model has been developed in her institution that sets out the consumer engagement mechanisms across these 5 levels. For MASCC, there are a range of considerations to make, and this annual meeting aims to start the conversation. For anyone who identifies as a consumer out there, we want to hear from you. We want to know your thoughts on the topics that are shown here on the slide. So if you think of these as questions, please feel free to get in touch with your answers to those or your reflections, or to enter these into the chat at the Q&A session or share with us on social media. I would love to hear from anyone who would like to register their interest in getting more involved in shaping this work. Thank you.
Hello, and thanks for having me at this meeting today. I'm going to talk to you about engaging the community in research, and I'm going to cover the what, why, who, when, and how. Before I start, I'd like to acknowledge the traditional owners of the lands that I am on here in Perth in Western Australia, and that is Noongar Whadjuk Budja. And I want to pay my respects to the owners and the traditional owners of the land and their elders, past, present, and emerging. Thank you. So I'd like to tell you first of all about Telethon Kids Institute here in Perth. We've had 20 years of an organisation-wide consumer and community involvement strategy. And I believe the ingredients to our success have been having senior level champions at all levels of the organisation, from the director and board down, having dedicated roles, training and resources, and it's a goal of our strategic plan. We have very strong networks with hundreds of committed consumers and community members taking part in activities across the Institute, and we have national and international collaborations. And I think the most important thing is to never move off message that consumers add value to research. So our aim at Telethon Kids has been to have the public posted at all levels. And that means that we want to see the consumer voice throughout the organisation. So I'm going to talk to you about how we have worked through involving the community in the past 2 decades. So first of all, I'm going to talk about what I'm talking about, what it is, and that's researchers, clinicians, consumers and community members working together to make decisions about research priorities, policy and practice. And having the community advocate for the translation of research results to improve health outcomes by becoming part of policy and practice. So why is it important? It's about getting the whole picture. I really believe, after having been a consumer advocate for nearly 3 decades, that unless you're listening to and including the perspective of the consumer or the patient, the public, whatever you choose to call them, you are not getting the whole picture, and you may be just missing the mark. So who would you be doing it with? You would be doing it with consumers, and depending on where you are, you might call these people patients, their families or their carers, but here in Australia, we call them consumers. And of course, then there's community members. They're people that may be interested in the research being done. They may have family members, or they're just have an interest in research. And of course, then there's members of the public and citizens at large who also, through their taxes, may be very interested in what's being researched. So when do you involve consumers in research? And I think ideally you would have them at all stages of the research cycle, from deciding what to research, deciding how you would do it, doing it, sharing the results, and then knowing what to research next. But of course, that may not be practical. You may already have a project that has started, and therefore you may need to start somewhere and move on. As I said, ideally, you would be doing it at all stages of the research cycle, but the best thing to do is to talk about where you might involve consumers with the consumers and community members that are part of your research project. So how do you do it? I'm going to talk to you very quickly about how we've done it and what we've managed to achieve by having dedicated roles in this activity at Telethon Kids Institute. So we, to support involvement, as I said, we have dedicated roles. We've developed a range of methods that have been developed to support projects that involve 1 or 2 consumers or community members. They involve larger groups and of course involve the wider community. And we've got a range of different methods that we use depending on the project and what sort of activities the researcher wants to involve in their particular research project. We've developed training workshops since 2007, and that's about implementing involvement. And for consumers and community members, it's about being an effective member of a research team. And since 2007, we've had over 3,000 people from across Australia attend 152 workshops. And because of COVID, we had to change our face-to-face delivery of workshops to being virtual, and we're finding there's not much difference, but it's a lot more convenient, and we're actually getting a bigger buy-in than what we might have had we needed to be travelling around the country and delivering them face-to-face. We also have a suite of resources available online on our Telethon Kids website, and then there's toolkits like the Victorian Comprehensive Cancer Centre and the Australian Clinical Trials Alliance. Both of those organisations have toolkits to support greater consumer and community involvement. And the picture on the right of your screens, you'll see there is a training workshop we just held yesterday at Telethon Kids, where we had 24 early career researchers working through a workshop to find out how they might start involving consumers in their research. The other thing that we have is very strong networks. We currently have over 400 consumer and community members involved in providing the consumer and community voice and perspective to research projects across the Institute. And then in March last year, we were contacted by researchers and community members who had concerns about rapid research being developed for COVID-19 without any involvement at all. So very quickly, we were able to establish a national community advisory group. And this particular group of people from ages ranging from 20 to 70 plus years came together and gave advice on over 20 projects. And they were national, international, and of course, local Western Australian projects too. So that's been a really successful group, and we're really proud of the way this particular group have come together to have a say in COVID-19 research. So we've been putting into practice for a long time now, and we are, as I said, having over 400 people having a say in research. And it's been for all sorts of research across the Institute, including lab-based research, such as cancer, asthma, autism, and cystic fibrosis. There's been an enormous growth in involvement activities in cancer research in the past several years due to changes from the funder, who have actually required consumer and community involvement as a requirement for funding. And consumers are helping and being involved in grant applications, plain language summaries, presentations, serving on committees and attending forums and all sorts of activities right the way throughout the Institute. So I'd just like to share with you a couple of good practice examples that are relevant to the Cancer Research Centre that we have at Telethon Kids. They have a community advisory group, which is made up of parents of children and young people who have had various cancers. The group was established approximately in 2015, and they meet 3 to 4 times a year. They're involved in a range of activities, including advising on grant applications, reviewing protocols, consent forms, patient information sheets, etc. And often they will be helping researchers write the required area for consumer involvement in their grant applications and developing plain language summaries. So it's been really a very successful advisory group, and we're just looking at ways now to revamp membership. So on the left, you'll see a picture of a little fella there, Ethan Davies. He had brain cancer when he was a very little boy, and his parents worked together with Telethon Kids to develop a fellowship, and they raised funds for this fellowship. And this is to collaborate with researchers doing brain cancer research from all around the world. And they bring visiting fellows, they support visiting fellows to come to Telethon Kids Institute to collaborate and conduct research. So Ethan's mum also is a member of the advisory group, and they are very, very strongly involved in a whole lot of activities across the Institute, as well as the fundraising activities that they do outside. So on the right-hand side, you'll see Andrew and his son Curtis. Curtis had ALL when he was a little boy, and his dad is a member of the advisory group. He's actually the co-chair, and he's been involved in all sorts of aspects that of the activities that the advisory group do. And one of the things that Andrew does is he serves as a research buddy for particular projects, and he might meet with a researcher 3 or 4 times a year, depending on the needs of what's happening, and just to get an update and to give ongoing input into the project. And then late last year, Andrew talked to me and then also to other researchers in the cancer area about the fact that Curtis was struggling a little bit at school, and he felt there was an opportunity to perhaps do some research in this area, that kids who'd had ALL and were at school and were struggling, probably there were some things that needed to be looked into and what sort of interventions can be done to help them. So Andrew is currently looking for funding for that research project. So it's just to give you a bit of an idea of some of the examples that happen across the Institute. So just finally, I'd like to just remind you all that no matter what sort of research you're doing, without having the consumer voice in there, you might be missing out on getting that perspective of people's lived experience and the sort of questions that they want answered, not just what you as researchers want answered. So I think it's really important. And someone said to me late last year, having research without consumers involved is like throwing someone a birthday party and then not inviting them to the party. So I'd leave that thought with you to have to consider as you go forward and think, are there opportunities for you to increase or enhance involvement in your research? Thank you.
I'm delighted to join the conference today and really would like to start by thanking the organisers for the opportunity to present to you today about some of the work we've done in creating a strategy around consumer engagement at the Victorian Comprehensive Cancer Centre. So before I begin, I would like to acknowledge the traditional custodians of the land of which I am on and joining you today, and pay my respects to their elders, past, present and future, and to all Aboriginal people attending today. So I have no conflicts to declare. But I think when I start by talking about the Victorian Comprehensive Cancer Centre, I thought to set the scene on what it is, who we are, and what are we aiming to do. So the VCCC is the acronym, so Victorian Comprehensive Cancer Centre, is a multi-site, multidisciplinary joint venture partnership between 10 medical research, academic and clinical institutions. And really that involves 7 hospitals, 2 research institutes and a university. And the logos are there before. They're all based in Victoria, Australia. And they are funded to really have the remit to speed up the process of cancer research into the future of cancer prevention, treatment and healthcare. And I think if the outcome is to improve patient outcomes, is that our end result? Then the question really lies in is what are the patient needs are and where is the patient voice in all of this? And I use the term patient, but really that's not the terminology we generally use in Australia. I know in parts of the world you use patient and public involvement. In Australia we use consumer and community involvement. And I'd just like to, for the sake of the talk, just stick with the term consumer for now. So by definitions, what is a consumer or a health consumer? So health consumers are people who use health services. So this can be the patients, their family members, carers and other support persons. And in brief, you could say it's past, present and future users of a healthcare system. And when we talk about engaging consumers, the term consumer engagement is used. And I really like this working definition because I think if we were all to live by this definition, we would all be practicing best practice. So what is consumer engagement in our working definition? It's used to reflect an approach that involves the development of meaningful relationships with a shared focus. This is underpinned by trust and mutual respect and a commitment for all involved to be in active two-way dialogue. The term consumer engagement indicates action that is more than simply taking part. And I think I've highlighted the terms that you can imagine are the most important in this. It's about building a working relationship. So for the VCCC to start on what were they going to do with consumer engagement, they referred to the production of an action plan, and just outlined on this slide is the work that was done regarding our aims, our methods and our results. So the aim really was to consult on the vision and supports required for implementation of consumer engagement. The methods were semi-structured interviews, and you can see the number of participants there. It was done as individual interviews or as facilitated group interviews. And there were also secondary online surveys that people, consumers, staff, board members, executive, we went across the organisations to do this consultation. And what came out in those results are really defined at the bottom. So what do people want and think will support implementation? Well, it's about principles and values, really defining what they are. Having proposed roles and mechanisms for consumer participation. It's also about creating resources and guiding documents to support the implementation. And we created this model of consumer engagement, which may not look new to anyone. It's always 5 tiers of participation when you look at consumers. But we went down the path of thinking, well, we don't want to reinvent the wheel. There are a number of really good frameworks out there. And so we've created this model based on and adopting the Cancer Australia National Framework for Consumer Involvement in Cancer Control. And the levels of participation that you see there in this span from left to right is informing, consulting, involving, partnership, and consumer-led. And I think you can appreciate that as you go across the fan from left to right, that you're actually increasing in the degree of consumer engagement or the level of participation a consumer will be involved in a project. What is really key to the Cancer Australia framework, though, is that you have 4 key factors: a committed organisation, capable consumers, inclusive groups, and a shared focus. Now, what we have done, we use this model, but then to make it more practical, we underpin this with examples of activities. So I'm not expecting you to read the table on the right, but what it is outlining certain activities that come within each of those levels of participation. And what we found for both staff and for consumers is that it actually helped them position themselves when they were involved in programs. It helped with tailoring communication, it helped with preparation, it really helped define the roles that they were playing in multiple programs across multiple projects. As you can imagine, a consumer can be involved in many parts of an organisation, and using this model and those activities, it really helped them prepare and contribute in a meaningful way. What we decided with the model was that people needed resources, and I think that was really glaringly obvious with the consultation. We chose to produce an online platform of resources, we call it the Toolkit, rather than a booklet or a report. And the reasons for this is a toolkit in this sense is a bit of a live platform. We can review documents when we get feedback, we can update new resources. And part of it is we put those resources out there for people to use. And we are really pleased, there's the link on the slide, but we're really pleased looking at the Toolkit metrics over the last 15 months. We've had over 10,000 page views, over 1,500 of the documents have been downloaded. And what is really pleasing is that over 6,000 of the visitors that came to our site scrolled down 75% of the page. The web, as we know, is a great place for information. It's trying to find the credible information, of course. And what we do is include a lot of that information and evidence in the content on the web page. And then there's the resources that can be downloaded. What is very pleasing is that in our top downloads is, the VCCC has created a consumer remuneration model that we implemented in 2020. That resource is actually our top download, which means other organisations are looking at that and considering a remuneration model of their own. The model of consumer engagement, which I shared with you, and the associated activities. And then there's the request for the consumer form. I think all of this and the support and the resources, there's a lot of resources on there, and I encourage you to go and explore the toolkit. these resources are not necessarily branded with our organisation. We have produced them so that you can insert your own logos, you can tailor to your own need. Part of our funding is that we produce these resources for everyone to use. And I just thought I'd show at the end is kind of applications of the model and how we are using it, and hopefully in the discussion that comes after this we can explore further. So one of the things is around tracking and monitoring. I think this is something that a lot of organisations don't do to a full extent. And when we started, we realised that we were really underestimating the number of times consumers were involved in our work. Using these numbers, we can then set, key performance indicators. And the table you see there is really the numbers of distinct times consumers were engaged at the VCCC in 2020. And that last number, if I can just show you in that bottom right-hand corner of 475 times, was quite an impressive number in 2020 of a year of a pandemic. You can use the model to then develop consumer engagement strategies, and MASCC is considering its own consumer engagement strategy at the moment. It clarifies the roles. As I mentioned, there's remuneration models, and we're really at the stage now where we're kind of developing our consumer-led initiatives, thinking of leadership, consumers as educators, and consumer-led research. So in the centre of our model is the phrase, consumer and community engagement is everyone's business. And this is exactly what it is about. And there are, of course, so many people to thank. So there are members of our Cancer Consumer Advisory Committee, and some of them are in the picture there. The staff, especially at VCCC, and in particular executive support, because that's very crucial. My details are on the slide, along with the toolkit and our organisation web pages, and I thank you very much for listening.
I'd like to report on a qualitative study we did looking at communication of cancer and its treatment to Aboriginal and Torres Strait Islander people. Here are my conflict of interest disclosures. I'd like to acknowledge that I'm presenting this from the lands of the Kaurna people of the Adelaide Plains, who are the traditional custodians of the land. I acknowledge their deep attachment to the land, and I acknowledge their elders past and present. Now, the picture hanging there is actually an Aboriginal painting of a clinic I used to do in Alice Springs that looks at both Aboriginal and white people collaborating with traditional and Western medicine to find an appropriate treatment for cancer for everyone. So cancer is a leading cause of death for both Aboriginal and non-Aboriginal Australians, but the cancer mortality rates are about 1.5 times higher for Aboriginal and Torres Strait Islander people. And it's all vital that all patients understand what cancer is and the treatments available, so that with their clinicians they can work out the best choices for themselves going forward. But there are many health professionals unsure of how best to communicate this information to Aborigines, who have a different idea sometimes of what cancer is and how it can be treated. So what we decided to do was to go out to health practitioners and support workers who regularly communicated this information with Aboriginal patients, and we interviewed them about what worked for them. The interviews ranged from 20 to 60 minutes. We did them either face-to-face, telephone or video conferencing, and we audio recorded them and transcribed them. The analytic technique was thematic analysis. It used an essentialist realist approach. It was a bottom-up type study, and what we were trying to do was look at the surface level of the data, of the thematic meaning. So the topics we covered in our semi-structured interviews is asking the people about what they'd learnt in that practice, how should health professionals consider speaking to Aboriginal patients, were there any specific words or phrases that they found helped with understanding, or perhaps it was images or metaphors? And how did they make sure that patients understood what they were told? And could they comment on the impact of non-verbal communication and how they establish rapport with patients? And then in terms of what to do about it for future doctors, do you think guidelines would help? How do you actually discuss the treatment options? How do you give information in an alternative way than using numbers like probability and percentages to discuss risk? And do you need any additional resources to aid communication, like perhaps phone apps and so on? And are there people like Aboriginal health workers that you regularly use to communicate? And finally, what are the sort of attributes of a health worker that does this well? And are there issues with overcoming sort of racially related barriers? So we covered a fairly wide spectrum. We interviewed 23 patients, roughly the same number of males and females, the whole spectrum of ages. 5 of them were Aboriginal and Torres Strait Islanders. They'd worked for between 1 and over 10 years with patients, and some of them had just contact once a year, but most of them were working in the field and saw at least 10 patients a year. Some of them were Aboriginal and Torres Strait Island health workers, and then there was the range of medical specialties and some allied health workers. They were located in the Northern Territory in South Australia, or in Australia, or in South Australia, where 3 of them were in the cities and 2 were in rural areas. So it was a fair mix of people that try and explain things and just to see if we could learn from them. So there were several results from this, and I'm going to summarise them. The first was the importance of creating a safe environment. Don't go in with any assumptions. Consider the actual physical environment. Aboriginal people often like being outdoors, so is there a window in the room? Sometimes there's a sensitivity about males talking to females or vice versa, so make sure that the patient and the provider of MASCC ask permission to ask questions and just build relationships. And they often talked about ask about home and family first, so you build a rapport before you get into the medical stuff. Always explain in detail what's happening, access the level of understanding that they have via their body language and non-verbals, and provide support for whatever their needs are. Their needs may be accommodation, it could be travel, or it could be just having someone about, that's an Aboriginal and Torres Strait Islander, to support them, and that will be important in their treatment. And then we asked them about strategies of explaining cancer treatment. Now, I've got to say that a lot of Aboriginal, traditional Aboriginal patients view cancer not as a physical condition, but sometimes as a payback for something that they've done to a relative. So, you know, breast cancer may be a punishment for some wrongdoing to an aunt, for example. So they often don't see our physical treatments as relevant to that. But in trying to explain what cancer is, some of the images that have been used that have been found useful by these practitioners, there's one that's a sort of a rusty car, and there's plenty of rusty cars out in the desert. And from a distance, they look okay, but as you get closer, you see that the insides have rusted out, and they use that as an example of cancer. A tree with spreading roots is an obvious example, and one of the radiotherapists used to talk about adjuvant radiotherapy as we've cut down the tree, now we've got to poison the roots, which was something that the people could understand from their normal lifestyle. And of course, blockages and things were either damming rivers or blocked plumbing pipes, and they could understand those sort of things. So metaphors, simple language, visual aids, repetition was all important. And we often asked the patients about what would have made communication easier. Fortunately, there's a lot of people who can assist in communication. There are Aboriginal interpreters, but there's many languages, so sometimes it can be difficult, and we have used telemedicine to try and find someone that speaks the same language. Aboriginal liaison officers are incredibly helpful, as are Aboriginal health workers. Even the people that escort the patient can give an insight into some of the needs of the patient. But it's very important that we're educated about culture. And there's a picture of me in my Alice Springs clinic with two of the palliative care workers who worked in the Northern Territory all the time, who taught me an enormous amount about how to look after the patients. And culture is very important. I've talked about the different views of cancer, but also there tends to be within a tribe a collective decision-making rather than individual autonomy. There's a strong connection to country. They particularly feel it important to go back to country to die. And so if you're looking after someone, you've got to be pretty accurate about that prediction to see if you can fulfill a very strong wish. And then there are times when someone won't turn up to a clinic, not because they don't think it's important, but they have cultural obligations like sorry business or funeral responsibilities that they see as far more important than looking after themselves. And then, as I've said, there can be a unique understanding of what caused cancer, and therefore some of the treatment may look irrelevant. We also need to anticipate contextual complexities. There are many languages and dialects. There are historical contexts that influence the patient experience. For example, the stolen generation who were displaced from their traditional families still bear the scars of that. There can be disappearance, as I've said, for other duties, and they can be difficult to contact. And there can be a lot of conflicts between Western medicine and Aboriginal culture. And sometimes the late stage presentation catapults you into more challenging discussions early in the communication. And people, some Aboriginal people may not necessarily tell you they don't understand, so they'll nod, but they're not really, so you've got to test their understanding. And of course, if you come in with any biases, then that's not going to help the communication. And so the personal qualities of good communicators were empathy and kindness, respect, patience, person-centered, so you actually listen to what the patient is saying, being honest with them, and just plain being personable. I think that's a good communicator for any clinician. So what are our next steps? Well, we want to use what we've found from these experts in Aboriginal communication to develop educational resources for less experienced health professionals, including medical students. When I first started doing a clinic in Alice Springs, I had to learn all this from scratch, and I don't think we should have to do that. So we may be able to pass on this information, and they'll start ahead in terms of effective communication. And the benefit of that is it ensures that the Aboriginal and Torres Strait Islander patients understand their cancer and its treatment, and therefore it improves their experience of the health system. They know why they're choosing the treatment, and in general that will improve the treatment outcomes.
Thank you for sticking with us all throughout the 3 days of the conference, and what a delight it is to finish on this topic, which I really see as being such a central part to the future of MASCC as we move forward. We have the pleasure of having our 3 speakers with us. You've just heard their presentations. Professor Ian Olver, Anne McKenzie and Dr. Joanne Britto. So really the floor is open to all of you. We're happy to answer any questions that you might have of the speakers. Thank you for your feedback during their presentations. It's really obvious that they're being really positively received. We will see your questions as they come up in the chat box. So while we're waiting for some questions, as the chair, I might just kick off and ask one myself. And it's for Joanne, but please, Anne and Ian, feel free to jump in. Jo, in your presentation, you really stepped us through the practicalities, you know, how at the VCCC you brought the concept of good consumer engagement into the reality, and that involved a whole lot of policies, a whole lot of support mechanisms for staff, and of course, support for consumers to feel like they're able to take on those roles and expand those roles as the programs needed them. Jo, can you comment on what you see as maybe the key ingredient or one of the vital kind of components of getting all that great work done with respect particularly to perhaps senior buy-in in institutions?
Yeah, thanks, Anna, and great question, because I think at the start, that's the most important part. And I'm going to quote our Executive Director, Professor Grant MacArthur, and he said, you know, it's up to us to do the heavy lifting. You know, those voices are so crucial and critical to what we do, but we need to make it happen. So I think in the framework, executive support or organisational support is really important, but I'll take that even as being, it's not just the organisation exec. Say you're part of a project team, it's the leadership in that project team. So maybe your whole organisation is not doing consumer engagement, but you want to. So as a project team leader, what does that look like? Well, for us, it is very much the consumer is at the table, the voice is there at governance levels. So all the project team level, the steering groups, advisory groups, expert reference groups, consumers are there. So I think one of the things we view it as is, if you think multidisciplinary teams, consumer voice is part of that diverse team. So you speak a language that everyone can understand and everyone can contribute. So I think, first of all, if it's at governance, then you probably will see it filter through the rest of the project or the program.
Thank you, Jo. I concur. I mean, I think what you're describing is the culture of an institution that enables that inclusion of that patient voice. And certainly at all those layers that you spoke of, there is a facilitation for that in the VCCC. That's a wonderful thing. So thank you. I want to extend the invite to Anne and Ian as well, and not just necessarily about executive senior support, but you know, what are the key ingredients, if you like, maybe the top three? Ian, you talked about priority populations and you know, giving voice to groups that historically have not had that platform. So if you and Anne can share in turn, what are the key ingredients that we really need to enable that patient voice to inform the way that care is delivered?
I think it was touched on a little earlier, perhaps, that I think education of the consumer to be a consumer who can represent the spectrum of consumers, because often there's one or two on a group, and rather than their personal experience, what's needed is what is important to the whole group. And so the institutions that want to engage have also got to be prepared to educate, and then be aware, though, that there are some groups, and I talked about Aboriginal and Torres Strait Islanders, that may need you know, special consideration in terms of representation, because their needs are quite different sometimes from non-Aboriginal Australians, for example.
Ian, thank you. It's such an important point. And do you have anything you'd like to add to that commentary as well?
I do. I think, as Jo said, having that senior level champions to drive it through the organisation. But I think another thing that's been very successful for us here in Western Australia has been having dedicated roles and to actually support and, you know, enable researchers to be able to do it. And of course, you know, support and enable the consumers as well. But for us, the other big thing has been the development of training for both consumers, researchers and clinicians to actually know how to do it, because some people, you know, might want to do it and they might want to be involved, but they don't necessarily know how. So rather than, you know, do it when you don't know how, they generally don't do it. So the training's been the thing that's turned the lights on for us.
Thank you. And I really like Ian's philosophy around institutions' responsibilities and clinicians' responsibilities to show others how to do this effectively. You know, those designated roles. Joanne, you're a consumer engagement manager. I mean, years ago, these things didn't exist or they weren't commonplace. So to do that heavy lifting is really important. And I want to take Anne's point and shift the conversation slightly. And there is a question there from Hannah as well. So I guess it relates to training and it relates to supporting researchers who are increasingly expected to demonstrate how their work has engaged with consumers from inception right through to application of findings. And a really neat policy piece that happened in Victoria probably a couple of years ago was around how grant schemes were altered to apply a heavier weighting to where researchers have demonstrated good consumer engagement. And it was at that time that, at least in Victoria where we worked, the researchers were saying, you need to help us do this because we don't know where to start and we don't know how to get to those people who are consumers or patients that have these skills and can advise us. And so Hannah's really seeking that. She's asking about, as a panel, some advice on how to best engage with consumers in a meaningful way. And I take that to be a bit of a where to start place. So if any of the panel can comment on that.
Can I make a quick comment? When I was a young oncologist and I first started going to meetings where they talked about the preclinical stuff, the mechanisms and so on, it became very clear that some people were excellent communicators in terms of being able to simply explain a difficult chemical pathway or whatever, and some people weren't. So I think it's to be able to communicate at the consumer's level that will engage them if you're a laboratory scientist, and it's a skill that can be learnt, I think.
Thanks, Ian. That's wonderful.
We developed a method that we call research buddies, and that came, we nicked that from the UK, and one of the charities there had research buddies to go and meet with the lab-based researchers. And so the research buddy's been very successful, and I know one of the organisations in the research institutes in Victoria has got a whole research buddy program, but basically it's a less formal role where a researcher and someone like Hannah might be able to do this through a consumer or patient organisation, is have a couple of buddies that you could meet with on a less formal basis, have a cup of coffee with, explain what your research is, and just get some general ideas how they feel about that. And, I've been working in this space for 18 years as a consumer advocate in research area, and I have honestly never had anyone have any bothers about animals and animal testing, etc. in the lab. So I think it's just a matter of, trying to develop a relationship with some consumers or patients.
Thank you, Anne. I saw a lovely example just this week with Monash Medical Centre in their grand round, so a big hospital here in Melbourne, talking about a new clinical trial to test the response to COVID-19 vaccines in cancer patients. And the first person to speak was a consumer who talked about why this clinical trial would be important for people in her position. And then it was backed up by, the professors and the researchers. And so just to have that model as a standard really set the tone for why this work is important. So Hannah, hopefully that gives you some tips. There is a question in the chat box as well from Bruce, who has been really active today. So thank you, Bruce. Your discussion's been so valuable in the sessions. And it's really about maybe a more generalised question, even though you do identify a cancer centre specifically. But, you know, as a consumer, how do you go about finding out about those toolkits that are helpful for me as a person to, you know, be able to give back or offer my services or do a better job, whether I'm being asked to review grants or give ideas? So Jo, maybe I'll start with you. Do you have any ideas for?
So I think we developed a toolkit, and we put our channels through the communication of our general broadcast, where we've got a large audience of clinicians, researchers and consumers on our book. So one thing would be, if there's an area you're interested in, sign up or subscribe to e-newsletters. I will say though, in our the toolkit that I talked about, we were very conscious that you don't want people to go, you know, having to look for it themselves. So in our particular toolkit, if you go to other resources, we've linked to international toolkits, we've linked to other toolkits within Australia. I think keeping consumer engagement as the focus, it's not so much about the organisation. We'd like to make it easier for people. So I know for our toolkit, we have done that. Some do it, they link, and you'll find people will link to other toolkits. So sometimes it's a case, once you get on one, you'll find out about more. But I can say subscribe to organisations you're interested in, whether they're consumer organisations or medical research institutes.
Thank you, Jo. And I know sometimes it's really about finding the right person to help navigate and link you, depending on your specific need.
I think in Australia, we're quite fortunate that each state and territory has a consumer organisation. So I think that there's somewhere else you might go to, Bruce, and have a look what's available in your state or your territory to see, you know, what's there and what can be helpful. And as Jo said, there's lots of linking on the VCCC toolkit to other toolkits in Australia and overseas.
And thank you. I wanted to pick up on something that was mentioned in your presentation. You talked about the National Community Advisory Group and how that needed to be quickly liberated to give advice on COVID-19 research because it was coming together so quickly. And I think there's been other impacts of COVID. I know in Joanne's institution, Joanne spent time with her consumers, really helping them transition to an online engagement platform to be able to continue their roles on advisory committees. So I really wanted to pose to the panel, and we've only got a few minutes left, but maybe what the silver linings out of COVID have been, or things that you've been trying to get over the line to support better consumer engagement that have been catalysed during the pandemic that might be helpful for us to think about keeping if they're working well.
For me, the silver lining has been you being able to use this virtual platform to talk anywhere in the world, and the fact that we're using it more and more, and that national group that we pulled together on a Saturday, actually, I just rang around and, you know, and asked people if they wanted to be involved. I said we didn't have any money, and that's, you know, we very much support payment for consumers for this sort of work. I said we didn't have any money, and all of the people who signed up, or we ended up with 22, they sort of said, we don't care, we just want to help. And, you know, even last Monday night, we still are meeting to talk about various COVID projects. So certainly been a huge silver lining that we now no longer have to fly everywhere, although I do miss that. We certainly can, you know, still engage and engage really appropriately and in a fantastic way.
That's wonderful to hear, Anne. Thank you so much. I'll just pass over to Ian and Joanne for any closing remarks before we wrap up.
Well, no, I think anything that makes communication easier is what we need. And I think post-COVID, we'll need to consider hybrids of face-to-face and virtual, because that seems to be the ideal.
Yeah, I'm with all the comments there. I think what we found with COVID was, I know people want face-to-face meetings, but they'd rather have a meeting than no meeting.
Yeah.
And it's making people comfortable so they can communicate and they can still get their points across. And I think sometimes that investment, you know, make the investment so that you can continue the engagement. And we had one of our more highly engaged years, I can say, in that time. The other thing that happened, not only did our meetings go virtual, but a lot of people put professional development and skill development. There were more webinars easily accessible. So I think it introduced a world of learning too for consumers, as well as the people that work with consumers. So there are a few silver linings, even though there was a lot of heartache, there were a few silver linings.
Thank you, Jo, Anne and Ian. There are no more questions in the chat box, and I really want people to be able to attend the closing remarks. It's been a really full 3 days. I'm so delighted we can be having these kinds of conversations in prominent global audiences like this. So thank you for your participation, your contribution, Ian and Joanne, and of course everyone who's engaging online and has been following along. And hopefully we see you face to face next year.
Thank you.
Thanks very much.
Thank you.